All right, guys. So you may have noticed that there's been a little bit of a change to our frequency of coming out with our podcasts.
That's right, but promise you that it's all for a good effort. We are now focusing a lot of energy on our newest project, Goals, the Gynecology and Obstetrics Adaptive Learning System.
So basically, Nick and I and a bunch of our friends have decided that we wanted to look into the realm of a more nationalized curriculum that is accessible to all students and residents. And so this is what we are currently working on.
So if you go sign up on the website, www.obgyngoals.org, you can create a member account, again, absolutely for free. And every week you will be emailed a brand new lesson that consists of a number of audio, visual, and video-based resources for your learning, a case that's supposed to simulate oral boards, a deeper reads page that covers textbook chapters, official documents from ACOG and the like, and finally, multiple choice questions written by us and our colleagues to be able to test your knowledge, boards or CREOG style.
And again, we are not ending the podcast. We are still going to be coming out with episodes that line up with our weekly lesson from Goals. But this just means that newer podcasts are going to be a little bit fewer in between.
Again, stay subscribed here to CREOGs Over Coffee. You'll still get a podcast every single week, but check out Goals to be able to supplement your learning and take it to the next level. We hope you enjoy it.
All right, guys, welcome back. This is Fei.
This is Nick.
And this is CREOGs Over Coffee. So today we're very excited to have Dr. Amed Logrono. Dr. Lograno is a PGY3 of internal medicine at Yale. And he is going to talk to us today a little bit about what your primary care doctor wants you to know as an OBGYN. So welcome, Dr. Lograno, onto our podcast.
Thanks for having me. I mean, this is wonderful.
So for kind of our learning objectives today, guys, it's a very broad overview, I guess, again, of what exactly, from a primary care perspective, OBGYNs need to know. And we'll kind of tackle this on a topic-by-topic basis of common problems that you may see as an OBGYN coming into your office that you may not be 100% sure what to do with, but you're pretty sure that there's something that you need to do. So Amed, let me start off, I guess. One of the things that we always do for a visit is get a set of vitals, right? Like everybody gets a blood pressure number. And I think that sometimes, like particularly as women get older and we're not thinking about blood pressure in the pregnancy context, we don't know what to do with blood pressure anymore, right? We're not sending off preeclampsia labs when they're 45 and non-pregnant. So where do we go from here when we see elevated blood pressures in non-pregnant women?
Yeah, I think that's a wonderful place to start. Blood pressure is like one of the most common things, right? So I think in non-pregnant women, we have to keep in mind that like blood pressure is a trend, right? It's a pattern. So, oftentimes in the office, when I see one blood pressure reading that's too high, I sort of delve into it a little bit more, try to think if there's something going on that's causing them to have a high blood pressure. More often than not with my patients, it's because they were late to their appointment and they were running into the clinic. And so that's probably why their blood pressure is high. So I think the most important thing to do when you see a high blood pressure is to actually check it again, probably maybe midway through when you're done with the interview or, at the end, just to make sure that it actually is a real, elevated blood pressure. But let's say you do have a patient who has high blood pressure, you check it again and it's also high, that definitely could be, a sign that they are developing high blood pressure. Normally, we would screen, once a year for younger patients up until, the age of 21. And then usually between 22 and 39, we'll screen. Most people do yearly, but the recommendation is at least once every 3 to 5 years. So that's kind of a low-hanging fruit for a lot of folks, and then anyone over 40, once a year, definitely. Let's say you're tackled with okay, this person definitely has this high blood pressure. What do you do? I think the best thing that folks can do is kind of just get a little bit more a sense of what's going on, what's their diet like, get a little more history about kind of what their daily habits are, getting more a sense of their anxiety and their mood and kind of these day-to-day things that might trigger your blood pressure. And that definitely will add a lot of context and sometimes might even be the solution.
Thank you so much for that, Ahmed. I think the next thing that I feel like I get a lot of is, I'll have a lot of women who come and see me, and I'm the only doctor that they've ever seen because they're like, oh, well, when I was younger, you took the OBGYNs here took care of me when I was pregnant. I had my babies with you. So I like you guys. I don't really want to go see, or I don't really think I need to go see a primary care doctor. But now they're 45, you do your annual history taking and they tell you like, oh yeah, my mom had type 2 diabetes and she was diagnosed sometime in her 40s or 50s. And I'm always like, oh crap, like when should I have started her diabetes screening? How do I start her diabetes screening? So coming from a primary care doctor's perspective, when should I have started that diabetes screening and how should I have done that?
Yep. So definitely diabetes, another very common thing that you guys definitely will face everywhere. I think certainly when patients who are in their 40s even have risk factors, a lot of our patients already have risk factors. They're overweight or they have a family history, like you mentioned. It's always good to check typically either an A1C, which is a good measure of how their sugar's been doing the last 3 months, good average. Checking that at least once. The recommendation says, once every 3 years is probably reasonable to do. Sometimes if you have patients who have multiple risk factors, overweight, obese, high blood pressure, all that, sometimes we'll check an A1C once a year just to see how they're kind of trending. Another good reason to check is, as it kind of helps to provide opportunity for counseling and opportunity for providing more advice about ways to prevent the progression to diabetes. I think one of the difficulties I have in clinic is when I have that patient who has pre-diabetes. So they're not quite there yet, but they're getting close. They don't have any disease. And so they're saying, Doc, I don't have anything wrong with me right now. Even though that is true, I think it's a great opportunity to sort of have that number and say, hey, you're not there yet, but you're getting close. And here are a couple things that we should maybe talk about to kind of prevent that from happening.
Yeah, kind of moving along those lines, another very common problem is obesity and sedentary lifestyle, right? And kind of all of the associated problems that go along with that, whether that be, pre-diabetes, as you mentioned, or dyslipidemia, atherosclerosis, deconditioning in general. How do you go about doing actual counseling for diet, lifestyle, obesity for your patients?
That's a great question. And I think, I will say that there's probably isn't one surefire way of doing this. Every patient's different, but definitely I think the way to approach counseling patients on diet and sort of lifestyle modifications is, first of all, getting a sense of, kind of where they're coming from, things, getting a good sense of kind of what they eat on a day-to-day basis, what kind of access to food they have. Oftentimes, are they the ones cooking or not? Because that can determine what they're eating every day. And so, I find that getting that context first is better because then it allows you to sort of make some real changes. So if someone tells you, hey, doc, I eat 3 meals a day, I eat veggies, but then they tell you, but at the end of the day, I snack on Cheez-Its or something. Then you at least you have that context where you can say, hey, there's a tangible goal that we can sort of start with, maybe cutting back on the Cheez-Its or cutting back on the soda. So really getting the story from them. And the way I tend to do it personally is I ask, just take me through the last 24 hours. What have you had to eat for the last 24 hours? And, people tend to remember what they ate over the last 24 hours, I would hope. And so I think that's a good that's a good opening question. And then, as far as things like exercise, I'll ask, oftentimes when we'll ask in social history, or we'll ask in like, what do you do for a living? I sort of get a sense of what their physical activity is like, and then another good thing to ask is kind of what's their environment like, where they live. Sometimes folks will tell you, I live, in an apartment building, but then there's a park nearby. And so that kind of provides an opportunity for us to sort of say, well, there's a park nearby. Is it close? How big is it? Do you think you'd be able to sort of walk around a few minutes a day? And so getting a good context, which I know that even in primary care, we have like 15 minutes per patient. We can't do all of it, but getting that story first is so important because it allows you to sort of set up goals that are tangible for your patient.
I think kind of going along the same lines, Ahmed, one of the things that I feel like a lot of our patients come in with is metabolic syndrome, right? And we've talked a little bit about type 2 diabetes, we've talked about obesity, lifestyle changes. What about assessing cardiovascular risk and, checking lipid panels and like starting statins, like doing all of those things I always feel a little uneasy about. And I'm always like, well, maybe you should have a primary care doctor now. But certainly, it'd probably be easier if I had already sent those labs and then refer to the primary care doctor.
Yeah, absolutely. So that's also a very common area you guys will hit on. And so, I think one thing that's important to recognize, thinking about our 40-year-old woman, is that a lot of our calculators for cardiovascular disease, the big one that we use, the ASCVD, has been predominantly made for patients that are, I believe, 45 and plus. And so really, you can try to use it in younger folks, but it doesn't necessarily apply. And so in sort of getting all this work up and getting the blood pressure and getting lipids and whatnot, which patients like these 40 to 75, the advice is to check lipid levels at least every 5 years for screening. Let's say you do hit, you have a 40-year-old patient and you check a lipid because you're screening, and all of a sudden their LDL, which is what we call the sort of the low density cholesterol, or aka the bad cholesterol, is all of a sudden elevated. It's greater than 130 is what we kind of constitute as like dyslipidemia. So then, what do you do? And so, a big portion of it, again, to start, goes back to counseling, right? Going back to discussing with them lifestyle modifications. But let's say you have a patient that has tried lifestyle modifications or is like, hey, doc, I can't do any of that. My life is too busy, or what do I do? Or let's just say you have a patient who has multiple issues, has blood pressure, has diabetes, has lipids all over the roof, and you end up calculating this risk score, which, this ASCVD risk is a risk of having coronary events over the next 10 years. And so let's say that is over 7%, which is our cutoff. Then at that point, you start thinking this patient would probably benefit from some sort of pharmacologic intervention that can help them improve their lipids. So usually, on kind of our side of things of primary care, that's kind of the way we sort of start introducing the idea of statins, is saying, your lipids are elevated, your risk score of having, heart disease in the future is greater than 7%. And so we definitely want to talk about diet and exercise, but maybe it's time to start a statin. And I would say from our end, I totally would empower you guys to, if you're interested in starting statins, you can. But I would say at this point, it's one of those things where if you find a patient with high cholesterol levels, it's time to send them our way so that we could talk a little bit more about how to manage it.
We'll see when the MFMU trial on pravastatin is complete of whether we end up prescribing statins. But I think for now we may leave it to you, Ahmad.
Thank you.
Kind of moving on from these topics about, I guess, the traditional like body health type of things. No, one other area where OBGYNs and primary care physicians, sort of as the folks who are at the entry to care, often run into screening and counseling issues is with mental health and substance use. And in particular, I wanted to pick your brain a little bit on substance use because many times we're fortunate in pregnancy that extensive alcohol use is fairly rare. And also, there's a lot of like extrinsic motivation from the sense of just being pregnant to cease using substances. But have things moved beyond like a cage screening for alcohol use? And then, like, what do you do for sort of more entrenched behaviors when folks get into their 40s and 50s in terms of counseling, screening, and arriving at a healthier place for your patients with substance use?
Yeah, it's a big question. I can say that we've moved beyond the cage questionnaire. There are still remnants of it here and there in the primary care setting, but we definitely have moved beyond that. One that is used is the screening tool that I've seen sort of in the past is this craft. Can kind of help you diagnose substance use or dependence. When it comes to substance use, it's really one of those things where I just ask kind of very openly, and sort of just, if I'm sitting there with the patient, you say, do you use any alcohol? The classic trend of questions: any alcohol? No. Any tobacco? No. And since any other substances, and I just sort of ask out openly, and I give examples. And I oftentimes, as long as you say kind of in a non-judgmental way, people are pretty open about it, especially at that age. They're like, yeah, I tend to use this or that, and really the key is kind of, again, getting a good sense of why and the how they're using it. And so asking a lot of open-ended questions. So how often are you using it? But then tell me more about kind of a day and how you're using it. And again, I think that's very helpful because it just gives you a sense of what are the things that motivate the use, and why are they dependent on it. Is there some component of mental health in play? Are there anxieties or depressions or mood changes that are contributing to it? Are there stressors? Once you have a sense of those things, then we're able to sort of give a little bit more help. One example I can give, and I give a shout out to our primary care clinic, is we have a subsection of the clinic that is called the Addiction Recovery Clinic, and so it's meant for patients who have different types of substance use and are interested in working on it. What's nice about it is that once you sort of identify these things, identify a particular substance and particular motivations behind it, then you can sort of have more nuanced conversations with your provider, but also with this particular clinic has addiction specialists, has psychologists, social workers, and people who you can talk to kind of really get down to the nitty gritty of it. And my sense in kind of just working in this clinic for the last few years is that that sort of addiction recovery aspect of it is becoming a little bit more and more common. And so, I would say that from your end, from the OB-GYN perspective, definitely getting the story, making sure that they're safe, that they're sort of not engaging in super dangerous behaviors to get these things. And then if you do have available to you, things like an addiction recovery clinic or addiction recovery specialists, that would probably be a good place to refer them out to.
Thanks so much for that, Ahmed. I think the other thing that I wanted to ask you a little bit more about is cancer screening as well. I don't think we need to necessarily talk about like cervical cancer screening or breast cancer screening. We do have episodes for those topics, but I think sometimes as OBGYNs, we kind of have tunnel vision and we like think about cervical cancer and breast cancer and that's it. But certainly, women are susceptible to many types of cancer. So what else should we be screening for? And I'm thinking about like colon cancer or like lung cancer, even skin cancer. Like what are the recommendations for those things?
Yeah, that's bread and butter primary care. So I'm happy to hear that other providers, other physicians are asking about this. So colorectal screening is one of the big ones, obviously, and we typically tend to start at age 50. Unless there are other reasons such as strong family history or one of those kind of rare genetic diseases, for most of the population, the recommendation is at 50. So from ages 50 to 75, you tend to screen these patients for colon cancer. What methods do we use? What modality do we use? A lot of that has kind of changed slowly recently, and it's also informed by your patient's preference. And I'll tell you from the primary care side, while colonoscopy is still the gold standard, it's tough to sometimes have a patient accept a colonoscopy or go in for a colonoscopy. There's a lot of different perceptions behind it. There's, informed stories behind it. There's a lot. And so when you hit those kinds of patients who, you're saying, well, you're at the age 50, it's time for colon cancer screening. Obviously, you get a good history, but if you bring up colonoscopy and they say, Doc, I don't know about that. I had a friend who got a colonoscopy and they ended up in the hospital. Then what do you do next? I don't want you guys to be stuck. I think the next step is, to have a conversation about offering other things, other modalities. One of the big ones that has come out recently is FIT testing. And so FIT testing, it stands for fecal immunochemical testing. You have just one stool sample. You give them a kit. They take it home. They only need one sample. They bring it back in, and it gets sent out. If it tests negative, then they can continue doing this yearly. And so that's a very appealing option for a lot of folks because it's not invasive. It's something they can do on their own, and you do it once a year. Now, if it's positive, and this is something that's important if you tend to go down this route and engage in FIT testing with your patient, you do have to let them know that if it is positive, you will have to recommend colonoscopy because that's the gold standard. And so I think, a lot of people sort of, when you present it that way, they understand and they tend to opt for the FIT testing. So that's a big one. And then there's other ones, there's a FIT DNA test. There's imaging, different types of CT imaging that you can do. Potentially there's flexible sigmoidoscopy or CT colonography that you can do once every 5 years. And then, the standard colonoscopy is once every 10 years if it's normal. All these are if it's normal. But I think in the day-to-day setting and kind of interacting with your patient, the most common struggle is to colonoscopy or to not colonoscopy. And when they say no, then offering other things like the FIT testing is probably the next best step.
And what about like lung cancer and skin cancer?
Yeah. So lung cancer screening is, I think, relatively one of our newer ones, newer guidelines. And by new, it's probably a little bit more than 5-10 years old. But anyway, we all do a bit of lung cancer screening, asking if people smoke. Nowadays, what's changed is that if someone has a history of smoking, they're between the ages of 55 and 80 years, and they have this either a 30-pack year smoking history and are still currently smoking, or they quit within the last 15 years, then there is a recommendation to offer a CT scan of the lungs to screen for colon cancer, to look for nodules. And that would be done at least once a year. I think you mentioned skin cancer was the other one.
Yep.
Okay. Yeah, didn't want to leave you hanging there. So, so as far as skin cancer, the guideline for skin cancer is a little bit looser. Obviously we're looking for things like melanoma, which is one of the most common cancers here in this country. Typically what we say is, anyone between 13 to 24 years, you should be thinking about skin cancer, at least at their annual visit, especially in older adults who've had a lot of sun exposure and whatnot. There isn't any specific test that one can do. Oftentimes the way they present is they'll say, Doc, I have this new bump. What is it? And really that's where you start. And in the past we would there were recommendations for doing like full body skin exams, and there's not a heck of a lot of evidence for that. I think the patient's your best ally in kind of telling you where the new spots are. But the thing you can do is kind of discuss preventative behavior. So using broad spectrum sunscreen, SPF 15 or greater, avoiding the sunlight at its peak hours if you can, wearing clothes that kind of, long jeans, long sleeve clothing that can kind of cover the skin. those are kind of the best preventative advices you can offer. And then, and then telling your patient, hey, skin, just kind of looking at your skin from time to time is an important thing. And if you find any new bumps or anything, just don't hesitate to show me and ask me about it, especially in our elderly folks.
All right. Well, Dr. Lograno, thank you again for joining us on the podcast today. It was really a pleasure and kind of a whirlwind tour through primary care, but I think be very much appreciated by our listeners.
Great. Always a pleasure to help out.
All right. Once again, this is Nick.
This is Fei.
And this has been Creogs Over Coffee.
So guys, if you enjoy the show, go ahead and go on to Apple Podcasts, Google Podcasts, Spotify, your favorite podcatcher. Give us a 5-star rating and review.
You can find show notes for this episode on creogsovercoffee.com, but remember, check out our newest project, Goals, at www.obgyngoals.org to supplement your learning even further with multiple choice questions, more audiovisual resources beyond the podcast, and oral board style cases. We think you're going to love it.
You can also find us on the social media on Facebook and Instagram at Creogs Over Coffee, on X at Creogs Over Coff 1. Make sure to like and follow.
And finally, if you have a question for us, a correction to this episode or any of our prior episodes, or just want to say hello or suggest a new lesson, email us creogsovercoffee@gmail.com.